Yeah. So good afternoon to all. So my topic is step-by-step approach in neuro-ophthalmology. But in a short span of time, it is very difficult to that you combine all the cases of neuro-ophthalmology. I would try to just sum up with one or two groups of patients that can be can present with a myriad of symptoms and signs, and step-by-step approach with the clinical examination, fields and imaging that can lead to diagnosis and the management of such cases. So what are the common clinical presentations for which that the patient presents to you in the neuro-ophthalmology OPD or in the ophthalmology OPD with the neuro-ophthalmological signs and symptoms, and they are also the indications of the imaging. First one is vision loss, for example, amaurosis, phagox, optic neuropathy, junctional scotoma, bitemporal hemianopsia or homonymous hemianopsia. These are the symptoms that the patient can present to an ophthalmologist primarily. So the other is anisocoria or ptosis. You can just proptosis, that can be because of the thyroid eye disease, orbital tumor, orbital pseudotumor or any other CCF, and diplopia or ophthalmoplegia of any kind, oculomotor or other supranuclear or internuclear ophthalmoplegia, gauge palsy and orbital lesions, headache with decreased vision or with field effects or some other your movement abnormalities, oscillopsia, and the last is the ophthalmoscopic abnormalities. Definitely these are the patient that is definitely coming to an ophthalmology with what? With optic disc edema or papilledema you can say, and that can be because of some other reasons. So now coming to the first case, a male child 12 years old consulted their family physician in Kanpur because of the what? Because of headache. Age is 12 years and this headaches they were becoming more frequent over the past years, and they were accompanied by nausea and photosensitivity, and that were relieved by sleep. So no pulsatile tinnitus, transient obscuration of vision or diplopia, general examination normal. It was referred to an ophthalmologist and he find out that the patient is having papilledema or bilateral disc edema. It was, now the patient was, because it was 12 years old, the ophthalmologist sent the patient to the neurologist for detailed workup because he didn't put his efforts to what this, whether this is papilledema or disc edema, what sort of it is. So neurologist ordered definitely an MRI because of the papilledema that was mentioned on the papers. Later the lumbar puncture was done to rule out IIH. The patient was again consulted another ophthalmologist who referred the patient to our OPD. This was the picture, as you can very well see over here. The blood vessels at the margin, they are not obscured. There is no hemorrhages, no dilatation of the vessels or accompanying any hemorrhage nearby the disc. So what do you think? It is optic disc drusen, bilateral. So confirmed by the pre-injection autofluorescence and with your ultrasound B scan. But the patient has already undergone MRI. Okay. So it was a case of bilateral drusen. So you have to rule out what? Pseudopapilledema. And in a younger child definitely, or in a mature adult definitely do an A scan also to rule out hypermetropia also. So it was a pseudo disc swelling, and it can be because of the small disc, tilted disc, elevated disc is superficial but unappreciated drusens. Now you have OCT also to appreciate the drusens. So case number 2. Again, this is a case of papilledema, not disc edema this time. 28-year female comes to the OPD with a history of recurrent attacks of headache for past 3 months with sudden development of intense headache. This is intense headache. Now this history is very important. So step-by-step approach means that everything is very important. So intense headache for past 3 to 4 days. She is a 28-year obese female and she was having restricted movement right side, that means abduction is deficient, and diplopia for 5 to 6 days during the episode of that intense headache, and decrease of vision in the left eye for past 1 week. No history of seizure episode or any other neurological deficit. So vision was 624 in the left eye, and as you can see there is an abduction deficit. Okay, abduction deficit in the right eye, very well you can see over here, not going to the that your angle of the little canthus. So this was the picture. So definitely this is not an disc edema. This is, you can say disc edema unless until you get the MRI done with there is increased intracranial pressure. So this is papilledema, what I am saying right now, because of the hemorrhages are there, no obscuration of margin, that your vessels at the margin with exudation. So this is definitely a papilledema with this constriction of field of the one side and restriction that your field effects on the other eye, generalized depression on the other side. So MRI, MRV with contrast was ordered. This contrast is very important. MRV with contrast, because in MRV, plain MRV, you don't inject any contrast. MRV contrast is injected to rule out something else. That means the external compression or the internal compression of the transverse sinus. That is the role of the contrast. And this is the pictorial representation of, this is your superior sagittal sinus, transverse sinus, and this is your sigmoid sinus, and this is IJV, where that your whole of the sinus blood from the brain is drained into. And this is what the MRV of the patient, you can see, this is the left transverse sinus, sigmoid sinus, and this is IJV. This is hypoplastic, but it, because this is constricted. And over here on the right side, you cannot see over here the sigmoid sinus. So it can be come down over here. This is the constriction, the stenosis or the constriction, or you can say the narrowing of the transverse sinus. So what came out to be? This came out to be a investigated for coagulopathy, 28 years old female, and she came out to be anticardiolipin syndrome. So considering that your cerebral venous sinus thrombosis, because intense headache for 5 to 6 days. That is what the important in the history was. And she was started on anticoagulant and the oral acetazolamide. She improved with all her symptomatology and with your papilledema and everything. And she was now on follow-up for last 18 months. So again, the third case, again, the same patient. 50-year-old female presented with complaints of headache. Now this time around tinnitus is there, decreased vision both eyes for last 8 to 9 months, 6-12 both eye vision, fundus shows chronic papilledema, because the symptomatology was there for 6 to 9 months. Field, enlarged blind spot, generalized constriction of field. This you can see chronic papilledema, constriction of field. This is your OCT, RNFL showing increase your thickness. And now this is a T2 weighted, you can see this is an axial section. Over here you find fluid. This is the sella area, fluid in the sella, that means empty sella is there. Pituitary is shrunken, that is the reason whole of that sella is filled with, that is what we call as empty sella. You are seeing the fluid over here. And this is your dilated optic nerve sheath. So MRV definitely was ordered, and over here you can find out. This is the transverse sinus, sigmoid sinus, IJV. Over here this is absolute hypoplasia, and there is definite stenosis of the transverse sinus, junction of transverse sinus and sigmoid sinus. So what was ordered? Next is you have to order DSA, digital subsection angiography. And on digital subsection angiography, this is your IJV, this is your sigmoid sinus, this is your transverse sinus. I'm just predicting it from below. And over here you can see definite stenosis of the junction of the transverse and stenosis, that your sigmoid sinus. And this is your what? This is when you have filled the dye, and this is coming over here. So this is exactly the transverse sinus, and it is going into that your superior sagittal sinus. Now what happened? This is what was done. The patient underwent balloon angioplasty with stent placement. This is the balloon over here, you can see very well. This is the balloon to dilate the stenosed part, and this is the mesh. Mesh you can see, I think. This is the meshed area. This is the stent, as just you put in your cardiac stent are put. So this is post stenting. You can see now DSA, everything has opened up. This is pre, this is constriction. Very few dye is going over here. So this whole of the dye is now going the other side. So you have relieved of the patient of the symptomatology and all of that what is coming out of this stenosis. So papilledema resolved. This is now on the right side, you can see the nerve fiber layer has come down. So now the coming to the case 4. This is now different myriad with the oculomotor deficits. Okay, a middle-aged patient with a history of gradual decrease in vision in both eyes and ability to move his left eye towards left side. That means abduction. So, but importantly, this patient was on hypertension, but controlled on one drug only. Important is controlled on one drug. I've checked all that, whatever that the chart he was having, it was controlled. So 612 and 618 was the vision. This is now you can very well see left, third, 6 now paresis. You can see abduction deficit over here. So what would you think? Hypertensive, 6 now paresis, many a times, because this is what the teaching is, don't get an MRI done, hypertensive, it would wait for 1 or 2 or 3 months, it would resolve. But no, this should not be done. Many a times, middle-aged, 40s, 50s, so hypertensive, but even though you have to order a field, and now you can see very well, the field is there. Bitemporal defect, okay, and there is constriction of the field on the other side also. And now this is the MRI. Axial section, very well you can see, T1 weighted axial section, you can see with contrast, okay. So this is what? This is a sella and suprasellar tumor. This is sella and going beyond sella superiorly, so suprasellar tumor having a lateral extension into the cavernous sinus. As the Kumudni ma'am has shown, lateral extension, because internal carotid artery is contiguous with your 6th nerve. So it is extending into the cavernous sinus, and now what is this? This is the 6th nerve. This is that your ICA, and this is third, fourth, and other nerves. So this is extending. This is the pituitary. This tumor was going over here and over here also. So sixth nerve. Initially, the sixth nerve was affected. So paracellular lesion, I'm not going into detail, all these cellular and paracellular lesion, which can go beyond the boundary of the cella, go upward, supracellular, go lateral extension of the tumor. So ocular motility, affected when pituitary tumor or any cellular tumor or supracellular tumor extend into cavernous sinus. Third nerve is the most commonly affected. Then comes your sixth nerve. The difference was with our patient that the sixth nerve was first affected. So again, this is what many a times you get. Hypertensive diabetic patient having third nerve involvement. Ptosis, you can very well see over here, your abducted eye, third nerve affected, pupil affected. So what would you do? Now there you have to go for MRI, imaging, and imaging with contrast. Definitely always, you just have to write imaging with contrast also. Fine. So this is an axial. This is a coronal section. Very well you can see over here, this is the cavernous sinus area. This is again the cavernous sinus area. This is the normal ICA on the other side. Okay, you can see the flow wide over here. And this is what? This is a partially thrombosed ICA aneurysm intracavernous. So partially thrombosed intracavernous aneurysm. So that is the reason the symptomatology was there. And this is the MRA. MRA, you can see this is the other side, and over here, this is your ICA, but over here, this is because partially thrombosed, so little bit flow is going through that part of the ICA, internal cavernous ICA. Over here, this is the same. This is normal. Okay, this is the ICA. On the other side, you can see very well the part going through the cavernous sinus. So case number 6, a middle-aged male presented with difficulty in depth of perception. Now, difficulty in depth of perception of moving objects and inability to move eyes sideways. Now, right eye was having restricted abduction and adduction, while left eye limited abduction and restricted adduction. So mixed bag of things. You cannot conclude whether this is an INO, left INO, right INO, Wabino, or 1.5 syndrome. But importantly, MRI shows 2 lesions. One in your, this you can see abduction. This is the eye in the primary gaze. What we have clicked the photograph, and this you can see. Now just the patient is asked to follow the finger, and you can see patient's own finger, right eye abduction deficit, even the left eye is not adducting. Fine. So now you can see very well the lesion, where the lesion lies. This is the pons, this is the lower pons, this is the medulla, and this is the fourth ventricle. The lesion is lying over here. The patient was having papilledema also, because it was causing obstructive hydrocephalus, and the symptomatology was increasing. So definitely something needs to be done. Importantly, one more lesion was found over here in the parietal cortex. This is at your frontal cortex. This is another lesion, and both were similar in their morphology. So definitely, because the fourth ventricle and the exit to that your medulla, it was obstructed, CSF was obstructed. So definitely neurosurgeon intervention was needed, and they have debulked the pons. And after debulking, the pontine lesion that was debulked, and biopsy was done and came out to be a caseating granuloma. So definitely 2 lesions were there, one in cortex, one in over there, obstruction was there. So ATT was started and the lesion resolved. This is after the debulking and starting you can see very well now the patency of, this is fourth ventricle, this is third ventricle coming over here, and patency is maintained. Now one more thing, that frontal lesion, that it resolved, but unfortunately on successive MRI, because they were done, the patient was having already a pituitary adenoma also, and it was again operated. So this is how you have to just think of getting the clinical examination, fields, and MRI. And MRI has to be ordered very meticulously. You have to write everything to the radiologist, because he would not be able to know कि मुझे करना क्या है उसके अंदर. So as an ophthalmologist, you have to know the paranasal sinus, brain anatomy, basics of CT and MRI, interpreting the scan, because what we do, film आती है, पहले हम just take the report and okay, अगर कुछ ऐसा लग रहा है, there is something, just refer the patient to neurosurgeon or neuroradiologist, or your neuroradiologist or neurologist. But you have to know about कि film पकड़ी है, I'm holding the film, whether this is a CT, कौन सा sequence है, कौन सा area है. So that is the reason you have to, basic ophthalmologist always tell you regarding the anatomy of the cella, paracellular, and other things. I'm not going into detail because now the time is up, because there are a little bit some slides were there with the what how would you identify the CT scan? How would you identify the MRI, which is to be ordered? I think this is beyond the scope because the time is up. Now, take-home message is, ophthalmologist may be the first contact physician with varied ophthalmological and other systemic features of a disease. So thorough ocular and systemic history, thorough ocular examination, and definitely systemic examination referral to other specialties like neurology. So ophthalmologist should provide the interpreting radiologist or interventional radiologist or the radiologist who is going to do the scan, the pertinent information regarding the patient's clinical profile, including the differential diagnosis you are having in your mind, the suspected location of the lesion to obtain the best neuroradiologic interpretation, and the information regarding the nature of the suspected pathology is important in deciding the protocol of the examination, and intravenous contrast is needed or not.